Health for Life. This is the first ever medical show on television that deals with prevalent health problems and concerns, and they do so in an easy to listen to question and answer format. To find out what we're discussing today and to introduce us to the visiting specialists, here is the producer and the host of Health for Life, Dr. Surendra Prasad.
Now, as we mentioned earlier, persons are living longer, and you're talking about putting in something metallic, a foreign body, and keeping the person's expected lifespan in mind. Is there an age at which you would prefer to then cross the bridge to the joint replacement?
Well, joint replacement, the recommended age is about 55 years old.
Okay.
So we usually say the patient who is the best candidate for a joint replacement is 55 and above.
Okay.
There is no upper limit, and there is no real lower limit. What you need to understand is if a patient gets a joint replacement, these joints don't last forever. So there's a 15-year expect the joint to survive. We've seen joints survive 25 and 30 years, but usually we will tell the patients 10 to 15 years. So that's where the dilemma is. If the patient is 20 years old and you do a joint, you expect that this patient will have to have a repetition of that surgery at some point, probably 35, 40. That's why we select 55. 55 gives you 65, 70 before you may need another surgery. And then most people, because at that age, patients are much less active, a bit more sedentary, their joints seem to last longer versus you put in a joint in a 25-year-old who wants to continue living his life like normal, he will destroy the joint faster.
Now, you talked about quality of life when the degeneration has reached a stage that is affecting the quality of their life. Elaborate a little bit more about what are these quality of life issues?
Well, usually the importance to most patients is can they do their normal chores on a daily basis?
Okay.
So we ask the patient, what is it do you do normally? Do you work? Do you do things around the house? Are you able to do things that you like to do around the house anymore? Most of them, when they come to you, is because they just can't. They can't climb the stair. They can't do their gardening anymore. They just can't walk around the house the way they like to do it, or they did it before. So that change in their quality of life, their inability to walk and do the things that they usually do, is the reason why they consult. And once they consult for this condition, and you examine them and do an X-ray and find that the degeneration is severe enough to merit a joint replacement, then you recommend doing a joint replacement.
And what do you tell the patients to expect from the surgery?
Well, the first and most important thing for a joint replacement is to relieve pain. So the patient who has done a joint replacement should be expecting that I will have much less pain or no pain. So that's the first expectation after a joint. You should have a better life with less pain or no pain. There are times when the pain does not go away 100% because your joint is a bit stiff still, so you tend to get sometimes stiffness in the morning when you wake up, goes away. Some people still have a bit of pain, but it's never, when they grade the pain that they had prior to surgery to after surgery, it's a complete different picture. So that's what the patient should be expecting. The ability to have less pain and the ability to move around in a better manner so that they can take care of themselves and do the things that they like to do best. So that's what we tell the patient to expect. And that is what we have been achieving in most part doing joint replacements in Guyana.
Now, when the patient has had the joint replacement, are there any limitations that they are placed on?
Initially, when you have a joint replacement, and we're speaking about a hip and a knee, which is what we do most in Guyana, the patient is able to walk the next day. Most patients have this understanding that when they get a joint replacement, they're going to be in bed for months. That's not true. The patient starts walking the next day, they make their first steps the next day, and then they're taken through a process of physiotherapy, and by 3 months, the patient becomes independent. Most patients become independent before then, but we advise them to give themselves 3 months where they would reduce most of the activity that they do to allow for the joint to heal completely. And what we're looking for basically is the bone cement interface that unites properly. There's no separation of the cement from the bone so that the patient could have a good functional joint. So limitations after surgery, minimal. You're able to get up, patient is able to walk, go to the bathroom, do things on their own. For the hip, there are some specific things that you need to advise the patient, and that is they must sit on a high chair, the bed must be elevated so it's high, and the toilet, they use a commode because the hip has the problem of dislocations. So you don't want the patient to sit too low so that the hip does not dislocate in the process of healing. Okay. Once a 3-month period has passed, most patients can go back to their normal, regular activity without any preoccupations.
Now, we talked about obesity as, I guess, increasing the rate of the degeneration. There's now some discussion when you were talking about the expected lifespan of a replacement. Tell us how obesity in the patient who has had a replacement is making the life of the orthopedic surgeon now a little bit more challenging.
Well, years ago, the obese patient was deprived of total joint replacements. And because it was the thinking of the orthopedic surgeons that this patient's weight will destroy the joint. So persons who are overweight were told to lose weight and then come to get your surgery. But that's not practical because their joint's not working, they're in pain, so they can't lose the weight no matter what you do. So the thinking has changed. Now, even though the patient is obese, once they're in good conditions with no major comorbid problems, we do their joints. And we have recognized that once you've done the joint and the patient becomes active and they know that they have to lose weight, they lose the weight. And I've had many examples of patients who've been large, and we do their joint and they come back to you and they've lost most of the weight that will now facilitate that joint to survive much longer. So obesity is a challenge, and it was a challenge, and decisions on doing surgeries in obese patients has always been a challenge. But we are recognizing now that we should not deprive them of the surgery because they get to lose the weight after the surgery and then their joint survives.
Talk to us a little bit about injections. I know recently there has been a marketing of a product that is supposed to enhance the lubrication, injecting it in the joints. Does that have a role in this particular degenerative joint disease?
The product you're speaking about is Synvis, or hyaluronic acid. Basically, what that product does, it tries to return the viscoelasticity of the knee, the liquid in the knee, to normal. I use a simple example. You walk into the doctor's office and the floor is dry. You do fine. You walk through, you get to your chair. The maid or somebody spills some water on that floor and you stepped on the floor and you go down because now there's no friction. So you just go. That's basically what Hyaluron does, or Synvis. It returns the viscoelasticity in the knee almost to normal. So the gliding of the, even though degenerate bones, they glide much better. So there's less friction, there's less irritation, there's less pain. Okay. Now, injections like steroids have their place, but need to be cautiously used. There's no point putting a steroid in an osteoarthritic knee that has no synovitis. There's no role for it. So unless your knee has a chronic synovitis, steroid is not the injection that should be put in the joint. Some people routinely put steroids as you turn up, you have osteoarthritis, you get a steroid injection. But that is falling into disuse, and there are specific indications for the steroid injection. Those chronic synovitic knees that are not resolving, you want to put the steroids so you can deplete the inflammatory process that's happening so that they get better. But you have to also remember that steroids have lots of side effects, and you don't want to cause those side effects, which one of them is overweight, and overweight actually causes problems for the same joint that you're trying to treat.
And one of the other things, you talked about the stiffness and the pain, and then the joint swelling, and sometimes patients may talk about fluid around the knee. What about those situations? And
well, the fluid around the knee basically is when the synovial sac has become so inflamed by the debris, and the normal equilibrium that the synovium or the synovial sac has for production of liquid and reabsorption of liquid becomes a disequilibrium. The normal knee, the synovial sac produces liquid because all of our joints need liquid for that viscoelastic movement of one part on the other. When the synovial sac is inflamed, it's unable to reabsorb the same liquid it produces. So the liquid accumulates in the joint. So you end up with a synovitis. The more liquid in the joint, the greater is the intra-articular pressure, and that causes pressure on the nerve endings, so the patients are in pain. So what can you do to a patient who has a really swollen knee with lots of synovial fluid? I advise firstly, unless the knee is really, really tense, I advise icing. Rest and icing, and I find that it works great. The knee that is really tense, we will have to take the liquid out. So we will do an aspiration. It's called an arthrosynthesis, where we will put a needle and we aspirate the liquid from the knee. And sometimes we can instill a steroid so that we can try to reduce the inflammatory process. And more modernly, instead of just aspirating the joint, a knee lavage is done. The knee lavage could be done or simply by inserting needles into the knee and washing the knee out, or you can go a little bit more sophisticated than that and use the arthroscope. So you can do an arthroscopic lavage of a knee that is having a chronic synovitis, which also gives you the opportunity to do a synovectomy, an arthroscopic synovectomy. So those are some of the options you can do for patients who have these knees that are swelling that are not getting better.
You talked about